Okay. Right. So welcome to this becomes actually the 11th session. So I apologize for yesterday I had to go away for to attend an emergency. So hopefully none will come up today, right? So now we have been doing the principles of management of labor. So the next important principle of management of normal labor is how do we monitor the progression of labor? Okay, how do we clinically go about the progression of labor, right? So remember, there are by looking at a woman, right, unless of course she has absolute contraindications for a vaginal delivery, okay, by looking at a woman we cannot tell her or tell beforehand whether she will deliver or not, because there are several things in labor that is not there during the antenatal period. What are these important things that determines whether she can deliver or not? Number one, the uterine contractions, right? Sorry. Right. So the first thing that is there in labor are uterine contractions. So beforehand, we cannot look at a woman and say, okay, this woman is going to have very good contractions. So to deliver, the woman needs to have good coordinated contractions, right? So that is only present in labor. Number two, the head, the fetal head needs to mold well. What is molding? Molding is to enhance the delivery. What happens is when the baby comes down the birth canal, the head sort of changes shape, right? And it is able to decrease or make its diameter smaller. How does it do that? One parietal bone slips under the other parietal bone, okay? And the frontal bones will slip under the parietals. And the occipital, right? Occiput or the bone, occipital bone, will slip under both parietals. Do you understand? So you have, you have two frontals, which is divided into two. You have two parietals and one occiput, right? So what happens is the parietals will slip under each other, and the frontals and the occipital bones will slip under the parietal. So basically the head can mold, that is called molding. And then that will, so if the baby's head does not mold well, there is a possibility that the labor might be difficult. The third most important thing that is there in labor is that the pelvic joints can stretch, right, which is called the pelvic give, okay? So when labor occurs and the contractions occur, the pelvic bones will stretch slightly and thus increase the diameters of the canal. Do you understand? So all these three are existent only during labor, and therefore we cannot look at a woman and say this woman might deliver or not. So the woman needs to be assessed along the labor or during the labor and not in the antenatal period, right? So the measurements that we used to do, like pelvic measurements or pelviometry, right, is not very effective because we are just measuring just the physical dimensions, and has not been found to be very effective to predict whether a woman can deliver or not. Is that clear, children? So therefore, it is very important for us to assess the patient very regularly during labor and find out how the labor is progressing. So what are the parameters or what are the things that we want to look at when we assess labor? Labor assessment is in different, there are several points in which you need to note down or say, right? These same parameters can be recorded on a partograph. Or what is a partograph? A partograph is a graphical representation of the process of labor, right? So therefore, a partograph can be maintained, right, during labor, but you need to understand what the parameters are that goes into that. So what a partograph does is it reflects the maternal condition, it reflects the progress of labor, and it reflects the fetal condition. Those are the three important things that the partograph will represent. Is that clear, children? Right. So we'll leave that aside for the moment and let us concentrate on how, as house officers or intern houses or doctors in charge of the labor ward, right, is able to measure the progress of labor. The first important thing which you look at are the parameters or the facts that we can get from the abdomen of the patient. Second set of observations or information which you gain are from a vaginal examination, right? So by combining these two, we can assess the progress of labor if we do it at timely intervals. Okay, right. So what do we check in the abdomen? Number one, we check the uterine contractions. Okay, so how do you check the uterine contractions? If it can be done by looking at an instrument, which is the cardio tachograph, and the tacho part is the other contractions. Okay, tacho means contraction, or sometimes it might mean uterus. So therefore, what you do is you look at the graph, and the graph will tell us how the uterine contractions are going on and how frequently they do come. Okay. The other hand, we can gain the same information by keeping our hand on the abdomen. The tightening of the uterus will tell us the start of the contractions and how long it goes, right? So normally we would expect initially to say whether it is strong, mild, or very strong, right, or average. It's very those. If you keep the hand on the abdomen, it is very, very subjective. However, if you do a tachography, right, and if you put the tacho probe on then of course we'll be able to, if you zero the machine initially, then we will just have a percentage like 100%, 70%, 40%. So we will have a sort of idea as to how strong they are, right? But to keep the hand on the uterus or the abdomen and then measure, it's extremely subjective. But of course, very experienced midwives, people who have been trained to look at it, can tell us whether it's a very good contraction or not. And normally good contractions will continue for about 30-40 seconds, but never more than 1 minute. So they continue for a long time, right? Mild contractions go off very quickly. Okay, so that is, so when we assess the labor, first thing we need to find out is how many contractions there are and whether they are mild, moderate, or very good contractions. Got it? So that's a clinical assessment. And number one. So what do we expect in early labor? Maybe 2-3 mild contractions starting off. As labor progresses, we would expect 4 to 5 very good contractions in 10 minutes. What does that mean? Each contraction should last about 30, 40, 50 seconds. And there must be about 2-3 minutes of relaxation in between. Another very good contraction, 1 or 2 relaxations, another good contractions, 1 or 2 relaxations, right? Because during these relaxations, the baby gets his blood flow. Remember, the uterus has 3 layers. The middle layer crisscrosses like this, right? The muscle fibers crisscross. And through this comes the blood vessels. So during contractions, what happens is the blood vessels will get crushed, okay? And the blood flow to the placenta will stop. However, because the placenta has a placental reserve, then of course, the baby will not feel a very good placenta with a very good placenta reserve. The baby is not going to feel the contractions very much because the placental reserve will keep on supplying the baby with good oxygenated blood, right? However, if there's a compromised placenta, right, when the blood flow gets cut off to the placenta during the contraction, then of course the baby will feel it, and then you might have problems with the baby's oxygenation, which may be reflected in the CTG at that point of time, right? Then the same mechanism will prevent a postpartum hemorrhage, because after the delivery, the uterus will contract into one prolonged contraction, right? And it provides instantaneous clamping of all the vessels to the placenta. As you remember, the placental surface will get about 500-600 milliliters of blood per minute when the baby is inside, right? So if you remove the placental surface, if the uterus does not contract violently and clamp all the vessels in between those myometrial fibers, what happens is she'll be bleeding 500 to 600 milliliters of blood every minute, right? And for her to reach the critical level of 40%, 50% of her total blood loss, it won't take long. As you understand, there's maybe about between 3 and 3.5 and 5.5 liters of blood in a person's body, right? So if you lose starting 500 ml per minute, right, then in 2-3 minutes or 4 minutes, 5 minutes, you would have already passed the level where it is difficult to salvage the womb. Is that clear? Therefore, this violent contraction at the end will prevent a woman's death, right? And therefore, that is why when postpartum hemorrhage happens due to uterine atony, and if it is very, very severe, we have to very, very quickly attend to it to save the woman's life. But that is beside the point. We are talking about the progress of labor. So the first thing is we need to measure the uterine contractions in any way, and at the same time we have to find out how many contractions she is having for 10 minutes. The second piece of information that we need to get, right, is how much palpable the presenting part is. So this is more easily said about the fetal head. And remember, when we palpate, we have to find out whether the head is 5/5 above the pelvic brim, or whether 4/5, 3/5, 2/5, and 1/5 above the pelvic brim, or 0/5, which means it's entirely in the pelvis. As a guidance, of course, remember, when you, if you are talking about 5/5 palpable, you know, when you palpate your head like that, but please go back to the video on the abdominal examination of which I have put online, right, of the obstetric examination, that will explain how we palpate about the head, about whether it is 5/5, 4/5 dominant. So remember, if it is 3/5 palpable, then it is a non-engaged head, right? 2/5, 1/5, and 0/5 palpable would mean an engaged head. You cannot talk about 0/5 if you have not felt the head at least once above the pelvic brim, okay, right? Because so before that you should have felt, otherwise all the rest you should be able to palpate and note down. So what happens during labor, children? With each subsequent examination, the head should be going down, right? So it should be in a 4/5 initially, or 5/5, then 3/5, 2/5, and 0/5. So basically with abdominal examination, each subsequent examination, remember, the presented part should have gone down, right? So these are the two most important examination findings which you need to know. So very, very simple. And of course, the fetal monitoring will normally be on the abdomen. So either you listen with the pinner after every contraction, right? Or every 15 minutes after the contraction, right? If it is a very normal thing which you can measure, or you can have a CTG for normally for high risk women, CTG connected. So that is abdominally over the abdomen, and the heart rates will be measured, right? So therefore, remember 3 important things that are checked in the abdomen for labor, or which you need to note down as well. Abdominal contractions, then how palpable the fetal part is, and the third is about the fetal heart rate of the baby. Is that clear, children? Right. From there onwards, we go to the vaginal examination. Vaginal examination to check for the progress of labor always has 4 things. Number 1, we need to check for the cervical dilatation. Number 2, we need to check for the cervical effacement, right? Number 3, we need to check for the station, right? And then number 4, we need to check for the fetal position. Okay. So plus the next one in vaginal examination, the 5th one is we need to check for the amniotic fluid status. Okay. So not 4, actually, there are 5 things that you need to check in the vaginal examination. Let's go again. Cervical dilatation, cervical effacement. Cervical effacement basically means how long the cervix is now. Okay. Station, that is in relative to the ischial spines where the presenting part is, right? It may be the breech or it may be the head, because we are talking about normal labor. Okay. So, and then the 4th thing is the position, right? Commonly, we need to think about the fetal head and not the breech, right? Because that is the easiest way to judge the position. And then the 5th thing is the status of the amniotic fluid. Okay. So those are the 5 things. So let's go over each of those. Number 1, cervical dilatation, right? Now, children, yeah, let me just plug in my thing, this one. So right, let's see whether this works. Right, let me share the screen with you all. Right, can you see my screen, children? Yeah, okay.
Yes.
Right, thank you. Right, now, how do we judge? Now, remember, this measurement of cervical dilatation by putting in the finger or trying to measure it or bring it out and measure it, not very effective. Okay. So what is important is there are some fixed ways in which you can think about the cervical dilation. Number 1, if you cannot put your finger into the cervical os, right, then the os is closed. Okay. Number 2, if we can just put in our finger into the cervical os, that is 1.5 centimeter. If you just measure your fingers, right, and find out this, normally in almost all people, there may be people with very thick fingers, so that is maybe 2 centimeters, but normally it is 1.5 in. Okay. So when you go in and touch the head, it is about 1.5 centimeters. Okay. Then if you can put one finger in, touching the presentive part, can move it slightly, but cannot put the second finger in, then it is about 2 centimeters. Do you all understand? If you can put 2 fingers in, barely, but you cannot move it, that is 3 centimeters. Okay. If you can put 2 fingers in and can move it slightly, that is 4 centimeters. Now we can judge 4 centimeters very well. Beyond that, you have to remember that you have to look for what is left to be objective. Now, if you look at the right, so if you look at the cervical dilatation, that is about from here to here, children, from here to here, we think that this is 10 centimeters. Okay. So remember, it is not always like that. So from here to here does not mean that it is always 10 centimeters. In different women, this diameter can be different. Do you all understand? But we postulate it and we take the 10 centimeter as full dilatation. However, in some women it can be 12, in some women it can be 9, right? In some it can be 13. Do you all understand? So just because we say full dilatation 10 centimeters, that's a very, very average one. What is important is how much of cervix is left. Okay. So what we do after 4 centimeters is try and find how much of cervix is left. So, right. So if we take, right, if we take this one, and here if we feel the head, right, what we do is we place the fingers here, 1 finger and 2 finger on one side. And here, shall we say, we place only 1 finger. Okay. What we do is we take any line across the midpoint. Okay. Doesn't matter where, right? Any line which has the most amount of cervix left, and we just find out across the midline how much of cervix is left. So here, so let's take another different color, I think. Right. Okay. So say here, this is 1 finger, 1.5. You can place another finger here. So how much is left? There is 3 centimeters left here. Here, shall we say we placed 1 finger and there's a bit more left until you get the fetal head. So shall we say there's 2 centimeters left. So 2 centimeters and 3 centimeters here, it's 5 centimeters left. So what is the dilatation? 5 centimeters. Got it? 5 centimeters left. 5 minus 10 is 5 centimeters dilated. Is that clear, children? Say when there's another one, shall we say like this? And you can feel the fetal head here. That's a head, okay? And the cervix that is left is only, shall we say this? This is cervix. Okay? So if you can, say you try to find out across the midline, say midline, in anywhere across the midline, these lines, okay, doesn't matter. Say here you can place, you cannot place 1 finger because some part of your finger will go across the fetal head. Here also you cannot place right opposite 1 finger, only partial fill. So what we do is we think, okay, here there's only 1 centimeter left. Here there's only 1 centimeter left, right? So what does that mean? In total 2 centimeters left, and therefore the dilatation has to be 8 centimeters. Is that clear, children? Got it? Right. Say we'll take another one. So say this is the, when we do the vaginal examination, you will get sometimes something like that, where, right, only this amount of cervix is left. On the other side, you cannot feel the cervix. This is all head. Okay, so here, shall we say, this is all head. Head, 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 head. This is all head. Okay. So now if we look at it to see, there's a small rim of the cervix left. So now when we look at the midline, we should always choose a midline that goes across the widest part of whatever the cervix is left from here. and not from here. If you measure it from through this, then you will see, you will think, okay, it is fully dilated, but actually there's a rim. So when you do a vaginal examination, go right round and try and feel the cervix. So shall we say, we cannot keep the whole finger, but part of the finger can be felt here. Okay, if there is a finger. On this side, nothing. So we will just postulate, because the finger is 1.5 centimeters. So 1 centimeter left. So this is what? 9 centimeters dilated. You understand? Right? So sometimes we might get something like this. Say, okay, oh, then we get a very thin rim of cervix all round. So probably when we do that, say you cannot, if you keep the finger there, you just 1/3 of the finger is felt here. And another one, you just put just 1/3 of the finger, which means what? About 0.5 centimeter left on each side. So which means what? Just 1 centimeter. So that is, this is also 9 centimeters dilated. Full dilatation means you cannot feel anything at all around the cervix. Do you all understand, children? Right? So that is how objectively that we will look at what it is. Look at cervical dilatation. Is that clear, children? Right. The next part is cervical effacement. Okay. Now, cervical effacement basically means you are just to find out, we are trying to find out how long the cervix is. One moment. Sorry. So, effacement means how long the cervix is. Remember, this understanding of saying 50% effaced, 40% effaced is not very logical. Why? Because we normally will not know how long the cervix is initially. Say, if you just write 50% effaced, that is not a very logical way of going. Why? If the initial measurement of the cervix is 4 centimeters long, and if you now find 2 centimeters, then the cervix is actually 50% effaced. Okay? If the initial length was 2 centimeters and now it is 1 centimeter long, again the effacement is 50%. You all understand? So actually it does not give us an idea about the how long the cervix is, unless you note down initially, okay, this is the length of the cervix. Got it? So when a 2 centimeter long cervix becomes 1 centimeter, that is 50% effaced. At the same time, if there's a 4 centimeter cervix that becomes 2 centimeter, that is also 50% effaced. So it is not a very good scientific way of talking about effacement. The best way to speak about effacement is by length. And how do we do that? We try to measure how long the cervix is. And how do you measure that? When you put the finger in, right? First of all, we will put one finger to touch the presenting part, and the other finger, you move along and come to the edge of the cervix. And when you draw it out, what you have here is basically the length of the cervix. Do you all understand? So initially that is possible. Initially it will be 2 centimeters, then it will become 1 centimeter or 1.5, 1 centimeter, then maybe 0.5 centimeter. You write down, okay. Beyond that, what should happen is, what you do is when the head is felt, the cervix will be very thinned out around the baby's head. So you go on the cervix, you come, and then you, like a ridge, and then you fall onto the head. So you can just feel it like a paper. So when it becomes very thin, it will be like just a paper, and that is what is called fully effaced. Okay. So if this is the fetal head, baby's head, right, and you have, say this, shall we say, you have this. Okay. So if the fetal head is like that, that's is not a good thing to hold. It's very difficult. Let me just get a paper or something. Right. Say if this is like this, okay. If this is the baby's head and this is the cervix, when you do like that, right, and you come still on the cervix, then you fall onto the baby's head. So the thickness is here. Do you all understand? So here it's becomes subjective. Okay, we say, okay, this is half a centimeter. Okay, then it becomes more thin, a quarter centimeter. Then it's very paper thin. There is no ridge at all when you come onto the baby's head, and you call it fully effaced. Do you all understand, children? Right? So that is how you talk about effacement. So with each subsequent vaginal examination, the cervix must dilate. So you must have more dilated cervix. Okay. With each subsequent examination as labor progresses, the cervix should be more effaced. Because with each contraction, what happens is the cervix will dilate and efface, dilate and efface. And that is how labor progresses. Is that clear? The third thing, which is important, is the station. And what does station mean? The relationship of the babies or fetuses leading or presenting part, right, relative to the ischial spines. Okay, so we take 0 as the level of the ischial spines. So if it is 1 centimeter above the ischial spine, it's -1. If it is about 2 centimeters above, it's -2. It's about 3 centimeters above, it is -3. Basically, -3 is a floating head. Okay, then -2 is, there's quite a bit of room or distance between that, and -1 means just about 1 centimeter. If the head comes below the ischial spines, it becomes +1. Then when you part the labia, you should be able to see it. If it comes 2 centimeters, right, it means you can just part the labia and you can see it, right? And +3 means the head is almost out. It is jutting out and it's not receding. Got it? So that is how we look at the station. And how do you do that practically? What you do is you do a vaginal examination. Go to one side, feel the ischial spine, and the other side you feel the ischial spine. And if you hit the head at the same level, ischial spine, head, ischial spine, you are looking at station 0. If you do ischial spine, but you have to go a bit above to feel the fetal head, and then you have to come down to feel the other side of the ischial spine, that is about -1. If you go a lot, it is -2, a lot -3. Do you understand? However, when you do vaginal examination, if you hit the baby's head first, or the presenting part, then you have to go around it and below it to find the ischial spine, right? That is, go above the presenting part, then it becomes +1. You all understand? Because if this is a head, you feel the head first, so it has come below the ischial spine. Then you have to go around it and then find the ischial spine there. Then of course it has traveled beyond the ischial spine. So it is become +2 and +3. Is that clear? Right? So that is something that you need to talk about, the station. Number 4 is something that you need to understand very much, right? Number 4 is the position of the baby or the fetus, right? Now, position means we are taking a fixed point in the maternal pelvis. It can be the symphysis pubis, it can be the sacroiliac joint, it can be the coccyx, a fixed point, and we find or we relate to that the position of the fetal head. And we say, okay, the baby's head or one point in the baby's head relative to the fixed point which you take is whether it is anterior or posterior. Okay, that is the fetal position. So let's make it simpler. If you take the pelvic outlet like this, right, and you divide it into 2 this way, one half is closer to the symphysis pubis and the other half is closer to the coccyx or the sacroiliac joint. Is that clear? Right? If you divide the inlet, right, in front will be the symphysis pubis and behind will be the sacroiliac joints and the sacrum. Is that clear, children? Right? Or the pelvic bone, right? So when you look at that, if the fixed point in the baby's head, which we normally take what? The posterior fontanelle or the occiput, right? In front you have what? My head is ideal to show the fetal bones, right? Although my frontal ones are fused, but in the baby, it is divided into two frontal bones, right? Then there are two parietals. Then there's a sagittal suture here, and behind there's the occiput. Okay, so the fixed point which we take in the baby is always the occiput, because the occiput should be the leading point in the baby's skull, because the baby's head should always be flexed, and it's the occiput that should come first. The more flexed the baby's head, less the diameter that the baby's present to the pelvis. Is that clear? So that is why we talk about occiputo, right? Where the occiput is. If the occiput is nearer to the anterior side of the pelvis, we call it occiputo anterior. Okay? If the baby's occiput is near to the posterior side of the pelvis, right? We call it occiputo posterior. Is that clear? Right? So therefore, we need to find out by doing a vaginal examination where the occiput is, whether it is anterior or whether it is posterior. If we talk about occipito anterior, right, that means the occiput is nearer to the symphysis pubis or the anterior side. If it is occipito posterior, which means it is nearer to the posterior side. Is that clear? So how do we judge? For you to understand how the baby's head move, you need to know the mechanism of labor. So in short, how does mechanism happen? Initially, the baby, so if you look at the sagittal suture in the baby, right, the sagittal suture is between the two parietal bones like this. Clear? And this is the sagittal suture. Okay? In the front, you get the anterior fontanelle here, or it's called the bregma. And it is bordered by four bones, one parietal, and the two frontal bones which are not fused, right? So therefore, there are four borders to it, and that is called the anterior fontanelle. The posterior fontanelle, which is in the occiput, near to the occiput, right, is bordered by how many? Three bones, parietal, and the occipital, right? So therefore, it is like a tricone, like a triangle. Okay, so that is the posterior fontanelle. So to recognize by vaginal examination, if you find four sides, it is the anterior and it's quite large. If you find only three sides, that is like a triangle, that is the posterior fontanelle. And in between, we have a suture, or what is that called? That is called the sagittal suture. Okay, so these three things we have to identify to find out where the occiput is, or the position of the baby. However, if you identify the anterior fontanelle properly and the posterior fontanelle properly, that is also enough. Okay. So now let's look at the mechanism of labor. What is natural is, right, remember, when the baby's head descends into the pelvis, that is engaging into the pelvis, that is called head engagement during labor, the baby's head will descend into the pelvis in the maximum diameter of the pelvis, right? Pelvic inlet. What is the maximum diameter of the pelvic inlet? It is not the antero-postero diameter. It is always the transverse diameter, which is the maximum diameter of the pelvic inlet. Do you all understand? And therefore, the baby's maximum diameter will descend into the pelvis in the baby's maximum diameter of the fetal head. And what is that? The baby's transverse suture, right? Or sorry, the sagittal suture will line alongside the maximum diameter and it will come down and it will descend into the baby's head, right? If I draw it, I will show you, right? Give me one moment. Right. So remember if you look at the pelvic diameter, children, see, this is the pelvic inlet. Pelvic inlet, this is the transverse diameter. Okay, that is the biggest, and the antero-posterior diameter is smaller. This is smaller. Okay. In the middle, if you take it, both this, the transverse diameter, and this, it's not writing properly, let's see. Both the transverse and the antero-posterior diameters are almost the same. It's like a Rauma. I have not drawn it properly. It's like a circle. Got it? In the outlet, it is more like this. The antero-posterior diameter is more than the transverse diameter. Is that clear, children? Right? Inlet, the transverse diameter is more. In the middle, it is the same. So it's like a circle. And outlet, the antero-posterior is more than the transverse diameter, something like that. Okay? So what happens? When the baby's head goes into the pelvic inlet, okay, the baby's head descends like that. Nose, okay, mouth. Can you see that? Because this diameter is the largest in the baby. Okay, got it? Right? So in the pelvis also, this is the largest diameter. And therefore, the head will engage in this diameter into the pelvis. So at this point, children, okay, if we do a vaginal examination, if we draw it like that, we will find the sagittal suture like this. We will find the anterior fontanelle here and the posterior fontanelle there. Do you all understand? So if you do a vaginal examination from here, we will find this. So if you schematically draw it, you just draw this line. You have a posterior fontanelle, sorry, anterior fontanelle here and a posterior fontanelle there. Okay? So that is what we are going to see. Anterior fontanelle here, so the baby's mouth and nose is on this side, right? And the baby's back of the head is on that, and this is the sagittal suture. So in the initial stages of labor, this is what you are going to feel when you are doing a vaginal examination. Is that clear, children? Got it? Then what happens is when the head comes down, then what it does is the baby's head or the pelvic canal is like a gutter. There are muscles there, the pelvic floor muscles. This head will hit these gutters and start to rotate. It will hit and rotate because from above the contractions are coming, and then what happens is the head will hit this gutter and start to rotate. Okay? The rotation can become or be to the front or to the back. Right? So when as labor progresses, what happens is, if you do a vaginal examination, what happens is because the head is rotating, the anterior fontanelle or the posterior fontanelle will be like that. Now we will no longer feel the anterior fontanelle because the head has flexed nicely. So we won't feel it, right? So see, it was initially transverse. Now it's rotating this way. It's rotating this way, right? So if you take the midline here, where is the posterior fontanelle rotating? It's rotating towards the posterior side. And on which side is the posterior fontanelle? Because when you do a vaginal examination, this is the left side of the woman and this is the right side of the woman. So initially, because the posterior fontanelle was on the right side, we call this right occipito-transverse. Right occipito-transverse. If the posterior fontanelle was the other side, it becomes left occipito-transverse. Do you all understand? Got it? So when it comes down, because the head rotates, right? It's rotating down. So actually it's on the right side, but it is rotated towards the posterior side. So it becomes what? Right occipito-posterior. Okay? Finally, what happens is the head might end up finally like this. So it is what? This is called, right, occipito-posterior, because it is not on the right or the left. It is directly, the occiput is down there. So this is occipito-posterior. So 20% of the labors at the end will be like this. Okay, or sometimes. But then again, it can rotate to the other side. Do you all understand? So now let's look at another one. Okay. So initially we do a vaginal examination, right? And so we feel the posterior fontanelle and we feel the anterior fontanelle here. So remember, this is the left side of the patient and this is the right side of the patient, because we are doing a vaginal examination looking at the or between the legs. Okay. So basically this position is not left or right. This is called occipito-transverse. Is that clear? Okay, because the sagittal suture is directly in the middle. Okay. Then when the labor progresses, now see, because it flexes nicely, now the posterior fontanelle, anterior fontanelle disappears. And now it is like that. Okay. Remember, this is the left side and this is the right side. When you feel it like this, what is happening? Because the posterior fontanelle or the occiput is rotating on the left to the posterior side. So what is this called, children? If you feel it like that. So obviously it's on the left side, right? So it is left.
Occipito-posterior.
Occipito-posterior. Excellent. Do you understand? And then finally, if the labor is going on properly, how should it rotate? It will end up like that. And then it becomes what? Occipito-posterior or direct occipito-posterior. Is that clear? So if you look at another one. Head. Initially, because the diameter is what? The transverse diameter of the baby or sagittal suture descends into the pelvis this way. So it is always occipito, most of the time occipito-transverse, right? Now, the next vaginal examination, you see the posterior fontanelle, which is the occiput, is going this way. It is rotating that way. So this is anyway the left side now, right? So what is this position? It's the left side. We are talking about the occiput, and where is it going? It's rotating towards the anterior side. So it is a left occipito-anterior. Finally, it will end up like this. Posterior fontanelle and sagittal suture. Okay? What is this? It's a direct occipito-anterior. There's no left or right because it's in the middle. Is that clear, children? So this is how, by vaginal examination, you judge the rotation of the baby's head. Is that very clear now? So every time you do the vaginal examination, you write what you have found by just simply drawing the circle and the occiput. Okay? A deflexed head, you will feel both the anterior and the posterior fontanelle, which is not good news as labor progresses. Only in the initial stages of head engagement, you might feel both. Then the head flexes. Okay? Then it hits the gutters and starts to rotate. Finally, just before delivery, it will end up as direct occipito-anterior, occipito-posterior. And then the head will slip under the symphysis pubis. And that is called crowning. Then the head is not going to go back with pushing. Okay? Then the head will do an extension so that the head is delivered. You all understand? Right? So it can be delivered either in occipito-anterior, occipito-posterior, which is rare. Most of the time it's occipito-anterior. And then the shoulders have come into the middle of the pelvis. So the shoulders to come out has to rotate because the maximum diameter of the outlet is antero-posterior, right? And therefore, the shoulders rotate inside. That is called restitution. When that happens, the baby's head also turns towards one of the mother's thighs, which is called what? External rotation, right? So it turns external rotation, inside is restitution, and then the baby's shoulders will be delivered. So initially the anterior shoulder can be delivered, so the small downward push, and then the posterior shoulder, the midwife who is delivering will lift it up slightly so that the posterior shoulder slips under the from the pelvis. Do you all understand? So this is how the rotation of the baby's head with each vaginal examination will tell you whether it is doing well. So if you do a vaginal examination, children, right? Say, initially, of course, in early labor, you'll be happy with this because that is posterior, anterior fontanelle and posterior fontanelle. So that is occipito-transverse. Next one you do, you feel the baby's posterior fontanelle only. Okay, you are happy, but it is still occipito-transverse. Then at full dilatation, also you have occipito-transverse. What has happened? The baby's head has not rotated and you are looking at trouble, right? You are looking at a transverse arrest. Is that clear, children? Right? So this is not good. So you have to deliver it probably by a cesarean section or a rotational forceps or a Keelan's forceps or a vacuum delivery. But however, the labor has progressed very badly or dystocially. Is that clear? Right? So then that is something that you need to understand, right? So there, so we'll stop the share now. Okay, right. Okay. Right. Now, did you all understand how we do a vaginal examination and find out how the labor is progressing? Is that clear? So this is how you need to think about the position and the progression of labor. So now what have we done? We have done the cervical dilatation. We have done the cervical effacement, right? Which you have, say, 2 centimeters, 1 centimeter, half a centimeter, maybe quarter centimeter, and fully effaced, right? And then the cervix will not be filled. That is fully dilated, right? You can't say fully dilated, fully effaced, because you can't find the cervix to talk about effacement, right? When it's fully dilated. So you say just fully dilated, right? And then you talk about the position of the baby's head, and then you talk about the station of the baby's head, and then If you just push the head up slightly, then amniotic fluid will come out and you say whether the amniotic fluid is clear, which is very important. Remember, you say whether the amniotic fluid is clear, meconium stain or blood stain, you need to make a statement about that. If you can't see the amniotic fluid, best to push the head up a bit and see what type of fluid is coming. Okay, that also gives you some impression as to what is happening with the amniotic fluid. The next few things that you need to do a vaginal examination is you can get an impression about molding. What is molding? As I remember, one bone slips under the other, and the two occipital and the frontal bones will slip under the parietals, right? To judge molding, if you put your finger onto the between two sutures, and when you press, if the sutures go apart, there's no molding. Okay. If you have to place your finger and push quite hard for the sutures to gut, that is molding is there, 1+. If you cannot push and get the bones apart, then there is severe molding. You understand? So you can talk about molding that way. So the way to judge molding is to find out whether between the sutures there is space automatically, whether the sutures are between there's absence, which you cannot feel anything, but when you push, it parts. And then even if you push, if it doesn't part, which means the sutures or the bones have slipped under each other. So there is maximum molding of the baby's head. Okay. And then comes the other thing, which we call caput. So the caput is something that the baby's, because the baby's head becomes very tight, there's venous congestion, and therefore the baby's scalp swells up, and that is called caput. We need to be very, very careful that we are looking to make sure that it's not a very large caput that comes out, because that is where the abdominal examination is very important. If the abdominal examination, the head is 5/5 palpable or 4/5 palpable, right? And we can see the station of the baby's head at +2, then there's something wrong. Why? It is not the actual baby's head that has come out due to the obstructed labor. It is just the caput that has come down, right? And that is something you need to think about when you're thinking about obstructed labor. You all understand? So our abdominal examination must always collaborate with our vaginal examination, right? So if you have a 5/5 palpable head, right, and the vaginal examination, we feel that it is -3 in station, yes, it is compatible. You all understand? So if there's a 3/5 palpable head, and in our vaginal examination, we have a -1, it is compatible. Okay. If we have a 2/5 or 1/5 palpable head abdominally, and we have a 0 or 0 station, then that is also compatible. You all understand? If we have a 0/5 palpable head fully engaged, and we see the fetal head at +2, that is also compatible. You all understand? Right? However, abdominally, if we with a 4/5 palpable, and we see +2 or +3 vaginally, what are we looking at? We are not looking at the fetal head. Actually, it's a caput that has come down. And you are happy thinking, okay, that if you just do a vaginal examination, then you are happy thinking, baby is about to deliver. No, baby's head is high up, and you are just looking at a caput. And it's obstructed labor, and the baby can die if you miss that. Do you all understand, children? So abdominal examination first, then vaginal examination, and that those findings needs to be compatible. If they are not, all the alarm bells in your brain must ring. There's something wrong. Got it? Right? On top of that, you do vaginal examination, it's occipital transverse. Then of course it is obstructed labor. If it is fully dilated, occipital transverse, 4/5 abdominal palpable, caput at +2, then you are looking at a transverse arrest. You need to deliver that baby, right? Most probably by doing a cesarean section. Is that clear? You cannot pull a baby's head from 4/5 palpable and you see a caput at +2 with the occipital transverse, right? You are looking at real trouble. So it's better to deliver it abdomen. Is that clear, children? Right. So this is how, of course, you need to put molding, and you need to put whether there's molding, and whether you need to put whether there's caput. Caput can be graded in different ways, +2, +3, but don't worry about that. You can just say there's caput, which you can fill, right? A small amount of caput is normal, but more severe caput or thickness is not very normal. Got it? So that is how you ascertain the progress of labor, by doing an abdominal and a vaginal examination. Is that part clear, children? Do you all want? There are some questions. There was slide drops in the connection. Just okay. Please explain caput once more. Well, basically, caput means is venous congestion, because the head comes down. There's a ring. It forms around the baby's head due to the vaginal walls or the muscular walls or the pelvis, and therefore the head blood that comes into the fetal head or scalp doesn't go back, so it swells up. So that is caput. Okay. If there is normally there will be a small amount of caput anyway, but if there's obstructed labor and the fetal head stays in one place, the caput will become more and more and more. Okay. So therefore, it is very important for us to understand that what we are seeing in the vaginal examination or feeling as +1, +2 may be simply a caput, while the baby's head is very high up, right? Or 4 to 5 with palpable abdomen. Is that clear? Right? So that this needs to be compatible for us to judge the progress of labor, right? So that concludes the monitoring of labor part, right? And again, if you do, how do you write? So if a proper way of writing it is what? So you see a patient, you put the on the BHC, you put the line, and what do you say? Abdomen, the cephalic, 4/5 or 5/5 palpable, right? Contractions, 4 in 10, good contractions, or mild or moderate or severe contractions. Then number 3, fetal heartbeat present, right? Fetal monitoring will come later. So that is abdominal. Vaginal examination. Os, say 5 centimeters dilate. Cervix, 0.5 centimeter effaced. Vertex at 0. Okay. Position, you can just draw it or just say right occipital anterior. Okay. Then amniotic fluid, clear. Membranes, you say minus. Caput, not there. Molding, plus. So it's very good. So we are looking at a good progress of labor. Then you come back 2 to 3 hours. Then the plan you need to write when your next assessment is. So at 8 centimeters, you should not be writing in 4 hours. At 8 centimeters, it's, if the baby is progressing, the labor is progressing well, maybe you should assess in about 1 or 2 hours, right? So next assessment, you put the time. Got it? So that is how you measure or check how labor is progressing. All these is converted into a partogram. Today, I'm not going to talk about the partogram. Please go and look at some videos in it, right? In the partogram, there is a maternal thing, maternal pulse, maternal temperature, right? And all. Then there's a part where it shows about the progress of labor. Contractions, how many in 10, whether they are mild, moderate, or severe, right? Then it will show the descent of the baby's head, that is -3, -2, -1, 0, +1, +2, +3. Then it will show cervical dilatation, right? Which will say how many centimeters, there will be a graph, right? Then it will show cervical effacement is not reflected there. And in some partograms, there will be the position can be recorded. And there will be amniotic fluid, whether it's clear, meconium stain or blood stain, right? Then the fetal heartbeat can be found. You can just draw it on that chart so that those are the fetal. So basically 3 things which you need to. Partogram is not the subject of our discussion today, but I just told you how to get all the parameters, right? And then you fit it into this graph, which you can look at it immediately. right? So that is the monitoring of the labor. Okay. So any questions there, children? Because then before I move on to other things. How are the VE findings changing the breach percentage? Yes. So breach, of course, it is sacrum. So we are talking about sacro-anterior and sacro-posterior. So vaginally, you need to feel the sacrum, right? So therefore, instead of occipito-anterior posterior, we talk about right sacro-anterior, right sacro-posterior, or sacro-anterior, or sacro-posterior, or sacro-transverse. Do you all understand? So that is how, that is a bit difficult for you all, but sacrum is what? When you're in, you can feel the bony sacrum there, right? So on one side will be the soft tissues, and the other side will be the bony tissues where you talk about the sacrum. So it's the same mechanism. The sacrum will negotiate the pelvis in the same way as it does as the head negotiates the pelvic canal. Is that clear? Right. Any more questions? Right. So that is actually the most difficult part which I wanted to tell you all, understand, right? The next thing which we need to talk about is thromboprophylaxis. That is the other, right? Now, what is thromboprophylaxis in Sri Lanka? Luckily, we actually do not have much problems with thromboembolism. It is more in different other countries, and in our country, women do not, the incidence of thromboembolism is very small. So therefore, we normally do not give so much of attention to thromboembolism than what other countries do. In other countries, where thromboembolism is commoner and it can cause death, there will be charts. The woman is assessed and given points about the risk of thromboembolism. Depending on the score which they get, lot of measures are put in to prevent thromboembolism. Okay. So in Sri Lanka, for genetically, we are not very much, our Sri Lankan women are not very much prone to thromboembolism, and therefore our measures are not as strict as it is in other countries by scoring. What are the measures that are taken? One is thromboembolic deterrent stockings can be worn during labor. Okay. Second most important thing to prevent thromboembolism is to keep her well hydrated without hemo concentration. And the third thing is mobility during labor. The more mobile the patient, we cannot expect, it is advisable for the woman to be very mobile during labor, right? She can adopt any position want, be seated, be standing, be walking around during labor, which is not a problem. And that also prevents thromboembolism, right? So just keeping on bed is not ideal to prevent thromboembolism. The next thing is certain medications can be used to prevent thromboembolism. That is medications that are given for thromboprophylaxis. Okay, low molecular weight heparins, heparin itself, all those can be given carefully, and there are certain protocols in place where it can be continued through labor or continued or started immediately after delivery, or how long it needs to be continued, whether it needs to be continued the antenatal period at the postpartum. So all that protocols are dependent on assessing the woman's risk, the history, right, and looking at the risk factors, each, that is the weight, everything, right, family history, everything, coexisting comorbid factors, all that, and then the protocol for thromboprophylaxis is put in for the woman's chart in each individualized management plan is there. In Sri Lanka, we don't do that more often because we rarely, and that is very luckily, we see thromboembolism in our patients. Is that clear, children? But that needs to be understood. The next principle we are talking about labor is how to use oxytocin. Okay, because if remember when to use. Now there are two understandings. One is we use oxytocin for augmentation. Augmentation is the process is there, but she is not progressing well. And therefore, we will increase if the uterine contractions are not good enough. We give oxytocin to increase the contractions, which is called augmentation. So if the labor is not progressing well, and we think or we detect that the progression is due to the contractions not being effective or not enough, then we have to augment the labor. Okay. Then the other process is that is initially starts on also herself and it doesn't really progress well, and therefore you start oxytocin, that is augmentation, right? Also, oxytocin can be used for induction of labor or start it off really, right? So where it was not there, labor was not there, you do so if you decide on delivering her, you might rupture the membranes and start on oxytocin. So you are inducing the labor by using oxytocin, rupture of membranes and oxytocin action. You all understand? So those are the two understandings that you must have. Now, let us look at the principle of using oxytocin, which you need to understand very, very well for you to understand how we use oxytocin in labor. Number one, there is a primary difference in what oxytocin is. The difference is if you use it in very, very small doses, you mimic labor contractions. The body mimics labor contractions. And how does the body, because the body also produces oxytocin, and how does it do it? It gives very small doses, and that causes contractions and relaxations in between. So that is labor. That is what we require. Okay. After delivery, or if you give a large dose of oxytocin, what it does is it gives a violent, prolonged contraction, right? And that is useful for the prevention of oxytocin. Prevention of postpartum hemorrhage. Okay. If we give a large dose during labor, the baby is going to die because that will cause a prolonged contraction. The blood supply will be cut off and the baby is going to die. Do you all understand, children? Right? So oxytocin, we use this special quality of oxytocin to use oxytocin in both instances. For the labor, for us to augment or to do an induction or to continue oxytocin in labor, we use very, very, very small doses. Okay. Then to prevent PPH, we give massive doses of oxytocin. Okay. To continue labor, we give milli-units of oxytocin. For the prevention of labor, we give 5 units. How much is that? 5,000 international units, milli-international units. Okay. Or if you give 10 units, that is 10,000 international units of oxytocin. While for labor, we use 2, 4, 8 milli-units, which are very, very small doses. You all understand? Right. Is that clear, children? Now let us look at the principle of using oxytocin, because everybody is a bit confused about how oxytocin is used. Okay. So let me just teach you the principle. Right. Let me just share my screen with you all again, children. Now listen very carefully. Can you see my board? Yeah. Right. See, what we require for labor, right? To continue labor, we should start with actually 2 milli-units per minute of oxytocin. Right? Got it? Then we increase this to 4 milli-units per minute. Then we can increase this to 8 milli-units, because what we do is for oxytocin, we double the doses all the time. Then we increase to 16. Then we increase to 32. Then we can increase to 64 maximum. Now this is normal labor room requirement or patient requirement. This is specialist territory. You do not increase over this without specialist supervision, okay? Because that can be dangerous. So this is the range that we need to think when we are giving a minimum which we can give is 2 millunits per minute. The maximum we should be giving is 32 millunits per minute of oxytocin to the patient. Is that clear? Now, we stop at any place here in giving oxytocin when we achieve 3 to 5 contractions in 10 minutes. That is our aim. Our aim is to achieve 3 to 5 very good contractions in 10 minutes. Right? That is effective labor. Is that clear? So, if we achieve this required amount of contractions at 4 millunits, then you stop at 4 units, which means you continue to give 4 millunits. If you are getting hyperstimulation, either you drop back to 2 millunits per minute or you stop until the hyperstimulation is over. Is that clear? If you achieve what you require at 16 millunits, then you continue this as long as we have the desired amount of contractions. If the contractions are not enough and we think that it is not enough, then you switch on to a larger dose. Do you understand? So when we start off labor, we start with, say, a certain amount of millunits. Every 20 to 30 minutes, you double the dose. 4 to 8, 8 to 16, 16 to 32, right? And so on and so forth until you achieve your desired result. Even at 32 millunits per minute, if you are not achieving a desired result, then you have to get very specialist opinion whether you can increase it further. Got it? Because that is dangerous area. Right. So now let's look at what we do in our labor room, because we do not have syringe pumps for all patients in all hospitals, children, where you'll be working. So how do we commonly do this oxytocin drips, right? As you know, commonly we put in 5 units of oxytocin in 500 ml of normal saline. Is that clear? Okay. So what we are doing actually is we are putting in 5,000 millunits, right, in 500 ml of normal saline. Is that clear? So if you want to find out what amount of normal saline contains, right, 1 millunit, then you have to divide 500 milliliters by 5,000. Am I clear? Right? So what does that mean? So actually in 0.1 ml of normal saline, if you put 5 units into 500 ml, actually 1 milliunit is contained in 0.1 ml of our fluid. Is that clear, children? So usually our starting dose is 2 milliunits per minute. So then if we want to give 2 milliunits per minute, then we actually have to give 0.2 ml of our solution per minute. Is that clear? Right? Now, if you want to double the dose, if you make it 4 milliunits per minute, then actually we need to give 4.4 ml of our fluid per minute. Now we cannot give this by using a drip because we do not have drips, right? That can give 0.2 ml per minute to a patient. That is only possible if we have a syringe pump. Okay. So if we have a syringe pump, we can start with 2 millunits per minute. If you want to increase, we can increase it to 0.4 ml per minute. If you want to make it 8 millunits, then from the syringe pump, you can give it at 8 ml per minute. So in the syringe pump, you have to give 8 ml per minute, 0.8. So if you want to make it 16, you have to give 1.6 ml per minute. And if you want to make it 32, then you have to give 3.2 ml per minute. Is that clear, children? Right? So this is if you are going to give a syringe pump. Now let's look at our commonest scenario which we have. Right? So say, now we know that 2 milliunits of oxytocin is in 0.2 ml of the solution which we make, 5 units in 500 ml of normal saline. Now, in the drip set which we give 5 milliliter, 1 milliliter, right? You know that normal saline, and in the you have a drip set, right? And if you look at the drip set cover, you will find that 1 ml is equal to 20 drops. Which means in the drip set, when 20 drops go in, 1 milliliter has gone. Okay? Is that clear? Now, if 1 milliliter is 20 drops, right? 0.2 ml is what? How many drops, children? 1 ml is 20 drops. That is 0.1 ml is what? How many drops?
4.
Yeah, okay. 0.1 ml is 2 drops. 0.2 ml are 4 drops, right? So this is equivalent to 4 drops per minute. In our drip set, children, we cannot give 4 drops per minute. Is that clear? Unless you use a burette set for this pediatric class. Normally in our labor rooms, we can't give 4 drops per minute. Is that clear? Very clear? So it's impossible to give 4 drops unless you are using a syringe pump where you can give the millunits per minute. Then let's look at 4 millunits. Can we give 4 millunits? We have to give 8 drops of that solution. Is that possible, children? Not really. But if we make it 8 millunits per minute, how many drops do we need to give? 16 drops per minute. Now, is that possible? It's possible because what do we say? We can arrange it to about 15 drops per minute, which is almost equal to this. So when we arrange oxytocin drip, which has 5 units in 500 normal saline and with our drip sets, and we adjust it to 15 drops a minute, which we do in our labor rooms, we are actually giving 8 millunits per minute. Got it? So we normally start off with 8 millunits, which is all right to augment or induce our labors, right? Now, when we double this, right, to 32 drops per minute, or shall we say just 30 drops per minute, we are approximately giving 16 milliunits per minute. Okay? When we make it 45 drops per minute in our drip sets, we are actually giving about 24 milliunits. So we have not actually doubled it, we have slightly increased it. Okay? And when we make it maximum at 60 drops per minute, we are actually giving 32 milliunits per minute, which is the maximum allowed dose safely to increase the drops. Do you all understand? Do you all understand the logic behind us saying 15 drops per minute. Okay, increase in 30 minutes to 30, increase in another 30 minutes or 20 minutes to 45, then put it to 60 drops per minute. Do you all understand? What we are doing is actually giving this, and this. Right? It actually does not matter the amount of oxytocin you put in the drip. Say if you put 10 units in 500 saline, right? We are actually, if we are giving 16 drops of that solution, we are actually giving 16 milliunits of that solution. If we are giving 30 drops of that solution, we are actually giving quite a high dose. Do you all understand? Right? If you put in a larger concentration of oxytocin, then with a small drip rate, you can give a large amount of milliunits, which you can calculate. But I've just worked out for you the common drips which we have. So actually here we start with 8 milliunits when we start at about 15 drops per minute. Is that clear? You all understand the principle now of giving oxytocin. Is that clear, children? Right? So in your mind, in your brains, you have to think of milliunits per minute, not drops or the amount of oxytocin. Okay? So in that way, same way, please calculate on your own. If you put 2 units of oxytocin in 500 saline, which means you are actually putting in 2000 international units in 500 of normal saline. So, you know, commonly sometimes you put 2 units in when for multiples, right? So just calculate for yourself, right? How many milliunits you are giving when you start off with 15 drops per minute with that solution. Clear? So you'll get a lower amount. Is that clear, children? Right? So this is what I wanted you to go into your brains, right? So that you understand exactly what we are doing. Okay? So let's stop the share. Right. So did that make sense to you all as to why we are using this amount of the way which we use oxytocin? Clear? Right. So that is the purpose or the understanding of or the principle of using these agents, right? So next time you go into the labor room, right, you can, if there's any colleagues around and that they have not come into this class or seen this, then you can ask these interesting questions, right, as to whether they understand the principles of how oxytocin is used. Got it? Right. The next principle which I wanted to talk to you about, I think I've spoken about all the principles, right? So let's get through the principles. Nutrition, then hydration, right? Then nutrition, hydration, thromboprophylaxis.
Analgesia.
Sorry?
Analgesia.
Analgesia, monitoring of labor itself, okay? Then use of oxytocin or augmentation, right? So I spoke to you 6, right? Next is the prevention of infection. What do we do for prevention of infection? Remember, the woman needs to be always very clean. Enema is not a must, but it probably is a very good way if you have time, because during the process of labor, every time the fetal head comes down slightly, then she will pass feces, which is very unpleasant sometimes during the labor. So there is contamination. So it's better if we can do it. It doesn't happen all the time. Doesn't happen that way all the time, right? But enema, I think, in my opinion, is quite a good thing if we can do it in time, so that the whole thing remains quite sort of not contaminated. Okay. Then the other things, we need to always keep the perineum clean, right? And then vaginal examination needs to be minimum, right, for assessment, right? For any delivery, any type, we need to make sure that everything is clean, the clothes draped, the stockings, proper drapings done, right? And so that everything is clean without, a contamination. So that is how you try and reduce the amount of infections that can happen, right? So that is it. So these are the things which I wanted you to understand. The next principle of labor. Now we have gone through a normal process, and now we have come to the part where the patient delivers. Now, delivery part. Now, fetal monitoring part I have not spoken about, which I am going to speak separately. Okay. The next thing which I am going to do, now we have come to full dilatation. Okay. And in full dilatation, what is the normal which I have spoken to you about? What is the time we allow? On epidural, primip 3 hours. On epidural, multip 2 hours. Without epidural, primip 2 hours. Without epidural, multip 1 hour. What does that mean? It means from the time you record full dilatation, hopefully you do it correctly. At the end of our stipulated time, we need to have this woman delivered. Okay. So this second stage, what is important is you need to understand when to get the woman to push. Right? So you get the woman to push, right? When she gets the urge to push, number one. Number two is when the fetal head has arrived at the pelvic floor. And when the fetal head or the placental part has arrived at the fetal head, you can see that the anus will become rounder and it becomes more open. Okay, so which means the pelvic head has arrived or the head of the baby has arrived. Okay, so therefore at that point of time, right, it is best to get the woman pushing, right? So it can come sooner or later, but remember, since after full dilatation we record that, depending on whether it's on an epidural or not, then we also have to write the time as to when the baby should be delivered or the delivery should be complete. So therefore, what you do is, if our stipulated time is 3 hours, say for a primip on an epidural, then we try to start her pushing by about the end of 2 hours if she has not been pushing. Of course, that time can come earlier, right, if the head has descended, but then normally we would start doing something after about 2 hours of after full dilatation. You continue to let her push for about 30 minutes. At the end of say 2.5 hours, still if she has not delivered, then you start to do something about it, either a vacuum or a forceps, and you try and get her delivered by the end of 3 hours. Of course, you need to expedite things, right, if there is fetal distress or a problem. However, you should not wait until the end of 3 hours and then try another 1 or 2 hours to deliver. Then your whole second stage will become 5 hours, okay, or 4 hours, which may not be very defensible in a court of law. So basically, once you start, or you have already noted down your full dilatation, you have to, of course, these judgments will vary with time and everything, but this is the rough sort of general idea you have to have, right? You start doing something actively, right, about 30-40 minutes before you end stipulated time, and then you get the baby delivered by that point of time. Okay, so this is something which you need to understand. So delivery can be normally, or it can be an instrumental delivery. Now once the baby has been delivered, then comes the principles of the third stage of labor. What is that? The delivery of the placenta. Once the cord is cut, then remember, cord clamping must be never less than 1 minute. You have to wait at least 1 minute for the cord pulsations to cease, and then it can go on till about 5 minutes at least, waiting for the cord pulsations to. Of course, if the baby is not doing well, if the baby is cold, if the baby is not crying properly, and if you feel there's a problem, of course, you need to cut the cord and give the baby to the pediatricians. But however, if the baby is pink, crying robustly, and you feel that everything is all right, then you can wait until the cord pulsation ceases for it to. So that is called delayed cord clamping. Is that clear? The next thing is, how do we delay the placenta? Now, what is important is to avoid postpartum hemorrhage, right? So this third stage can be managed in two different ways: without intervention or active intervention. Okay, so you can wait without intervening, or you can actively intervene in the third stage. So each of these have their plus and negative points. Okay, now what is active management of the third stage? Active management of the third stage is when the baby has delivered or when the anterior shoulder has come out. See, when one shoulder comes out, then definitely there won't be any shoulder dystocia, the baby will be delivered. So then you give a massive dose of oxytocin or uterotonic agent at that point, right? Which is normally 5,000 or 10,000 international units, or 5 to 10 units of oxytocin. When that is given, what happens is, say the placenta surface is constant. It doesn't change. The uterine surface, which sticks onto that, is also constant until the contraction. When we give a massive dose, what it does is, of 5,000 international units, the uterus contracts violently. And what does it have? What happens? The uterine surface becomes small, right? So what happens to the placenta? Because the placenta surface doesn't change, and it shears off, galvanizes, comes off. So that is how the placenta is made to detach. Okay, it should physiologically also, it is the same mechanism, but we are giving oxytocin for a more violent contraction. Now when that happens, now the placenta has detached, and how do we see that clinically? There's a deviation of the uterus to one side, there's a gush of blood, and since you are holding on to the cord, there will be lengthening of the cord. And then you understand clinically, okay, the placenta seems to have detached. Okay, now why do we give controlled cord traction? Simply because we have made the uterus contract, okay, violently and artificially. And what happens if we don't pull it out after detachment? We will have a retained placenta. Got it? So therefore, what we do is, to prevent placental retention, we do the pulling. So what we do is controlled cord traction. You all understand, children, the basic logic behind the third stage. So the active management of the third stage will incorporate what? Giving oxytocin either after delivery, there may be different practices, or after the delivery of the anterior shoulder of the baby, right? We give 5 to 10 units of oxytocin. Then we wait for signs of placenta separation, right? Or until the cord passage says, if you are waiting for delayed cord clamping. And then we give controlled cord traction and deliver the placenta. So that is active management of the third stage. Now, active management of the third stage give us two small advantages. Number one, the chances of the woman losing more than 1 liter of blood is reduced. Okay, and the chances of the woman having a postpartum hemorrhage is reduced. That is the advantage of our doing the active management of it. Doing nothing, right, which is physiological, just waiting for everything to come out on its own, right, will slightly increase the chance of postpartum hemorrhage from about, I remember, from about 25 in 10,000 to 49 in 10,000. I can't remember the figures now, right? Basically, for you all, what you have to remember is it increases the active management of third stage will decrease the amount of postpartum hemorrhages and will decrease the amount of the woman losing over 1 liter of blood, right? So those are things you have to remember that speaks for the active management of the third stage, right? So that is the end of the third stage. So once that is done, what you do is if episiotomy is not essential. So if the head is going well and if you manage the labor well, right? Of course, if there's an instrumental delivery, you need to empty the bladder, which is a different discussion. And an episiotomy may be required if you are doing an instrumental. If it is just a natural labor without instrumental delivery, you can give perineal support if you want, and you try and stop the head from extension very quickly, and therefore you can slowly with control you can deliver the baby's head, in which case there may not be tears, but however there can be tears. So if you feel that it is not happening, then of course you can do a episiotomy of the local infiltration. Once delivery is done, then you have to do the repair. Of course, you need to identify whether there are tears, right? Whether if there are tears, you have to suture, and then you need to do a proper episiotomy repair. So you all need to go and find out what are the degrees of perineal damage. The perineal damage is classified. Please go and find out what is classification now, because you may be asked about it. So from minimum, if it's a tear from minimum, then it can go up to the tearing of the bowel mucosa, right? So the degrees are there. So please go and check it out. I'm not going to teach that to you all now. And depending on that, you will need to do the repair either the theater or in the labor ward itself, which you can do. You need to be trained to be able to do a proper perineal repair, and you need to know the degrees of perineal damage. The next thing you need to know, I'm not going to teach you that, right? How to repair an episiotomy, number one. Number two, what is cut during an episiotomy? What the vaginal mucosa, what muscles, what types of muscles. And remember, the episiotomy is normally angled between 45 to 60 degrees towards the right side, starting from the posterior portion, right? There are medial episiotomies, but that is no longer much used because it can extend onto the rectum. Normally, it is angled 45 to 60 degrees, starting from the posterior foreshead, and then it is angled. And usually, because most of we are right-handed, we tend to give the episiotomy towards the right side. However, logically, there's no reason why we shouldn't give it onto the left side as well. Okay, right? Not two, but one, either to one side or that side. Got it? So that is how then you should be able to suture it. So that please find out what suture material is used, whether it's absorbable or non-absorbable, right? What type of, whether it is polyglactin or whether it is braided or non-braided, right? All that you need to be able to understand, and right. So that is the active management of the third stage, which I have to discuss, right? And then these are the principles which I wanted you all to know about labor, right? Is that clear? So in the subsequent lectures, we will conclude now. I will just answer the question. Subsequent lectures, we will discuss the problems or how specifically different problems are managed, like diabetes, large babies, or intrauterine deaths, right? Then hypertension, right? Preeclampsia, all that we will discuss these problems in labor separately, which we can discuss at a later stage. Then I will also take another one about the fetal monitoring in labor, where we'll be doing the CTG and the other fetal blood sampling, that is scalp sampling, all that we will, and twins and all that. And then another lesson we'll have to talk about postpartum hemorrhage, which is a separate thing, plus other problems that can occur in labor, like maternal collapse, right, cord prolapse, all those we will discuss in a separate way. So all these are different topics which has to be discussed separately, right? Okay, I'll just take the questions because it seems to be late. Yeah, and we'll see what you have. Oxytocin millionunits per minute to how long? Until she delivers, right? Once you start the children oxytocin, if you are starting it off due to the fact that the labor is not progressing and there are inadequate uterine contractions, you are trying to augment the uterine contractions, then you continue until she delivers, right? However, if she has violent contractions and she is hyper, if there is hyperstimulation, then you will get more than 5 to 6 contractions in 10 minutes. In that case, of course, then you have to either stop, right? And then when you stop, you wait until the contractions are come back to normal, or if it is less than normal, then it's best to start the oxytocin at half the dose which she was in, which gave her hyperstimulation. Okay, say if she was going at 32 millionunits per minute and you get hyperstimulation, then make it 16 millionunits per minute and restart when the effects of hyperstimulation has gone off. Usually it is fetal distress. So if that is settled, then you start at half a dose and see whether you can achieve the 3 to 4 good contractions in 10 minutes. Okay. What's the best time to start a partogram? Now, these are two, that's the question. These are two different things. See, there are patients who come in labor. Okay. And if it's more than 4 centimeters, then when you put her in the labor, you start the partogram. If she's 7 centimeters, you start it with 7 centimeters, right? So I'm not going to go into specifics of a partogram. Please learn that yourselves, right? So you start the partogram if the patient is in labor from the point where she enters into the labor room. However, there's a different set of patients where you induce without them coming in labor. So usually you are looking at a woman, if the cervix has been ripened, say you are inducing them at say 2 centimeters, 3 centimeters, and they are not in active labor. Sometimes you will be drawing long lines if you are just, because if she's in the latent phase, they will be just drawing a lot of lines on the partogram. So it's best to start a partogram when the woman is in the active phase of the first stage of labor, right? And the minimum which you can start that is at 4 centimeters. Okay. So that is your alert line, right? So whatever you do in the WHO recommends 4, if the other line to be drawn 4 centimeters, 4 hours, right? So if the change, if it crosses this line, then you need to do something. But some units will make it 2 hours, some will make it 3 hours, some will make it 4 hours, but that you have to learn by yourself. I'm not going to cover partogram here. It is very, very basic and there are so many videos on it. Okay. How to manage a patient coming already in labor to hospital? Well, if it is coming in labor and the patient is more than 4 centimeters dilated and in the active phase, please put her in the labor room. Okay. And then you manage the labor the way we just discussed, because we only discuss normal labors. Okay. So these are the principles of management which you need to know. A role of beta receptor agonist in uterine hyperstimulation. Okay. Now, if there's uterine hyperstimulation, there are we can use beta agonists to reduce the contractions, right? What are these beta agonists? There are several of them. Number one, we can try and use, which is expensive, which are oxytocin antagonists, right? Which we don't have in Sri Lanka, number one. However, that can be used if necessary. Second thing, there are uterine, it's not a beta-2 agonist, but it can be used if necessary. Then there is ritotril, right, which can reduce the number of contractions. However, it is not commonly found. Then there is salbutamol. However, it gives a lot of side effects like tachycardia and different things, so we hardly ever use. Nitroglycerin may be used, right, in but however, it is rare use. Nifedipine normally we will not use in a labor room usually, because sometimes once we give nifedipine, it is very difficult for us to get the uterine contractions back. So the best way to treat hyperstimulation is stop the oxytocin, hydrate the woman, and wait until its effects go off. Remember, these are milliunits, right? and they are the half-life is very, very short inside the body, and therefore, once you stop the drip, the effects will wear off very quickly, right? So till then, you need to wait. But if there is a prolonged contraction with bradycardia and problems, you can think of these agents, but sometimes they may not be effective. Okay. Next, what is the place in uterine massage in retained placenta? Well, this maneuver, which is uterine massage, can be practiced, but sometimes some use a maneuver which is not recommended at all because it is extremely painful. You get the fundus and all that, you start squeezing, and it's supposed to get the placenta out, which has been described, but please don't do it because it is extremely painful, right? Massage you can, but the problem with the retained placenta is not uterine atony. The problem with the uterine placenta is a sustained hyper, a larger contraction which has happened. It has what is this? A sustained contraction. So massage is not going to make any difference at all. Okay. So you all understand, retained placenta is because the uterus has clamped over the placenta and it is retaining, right? So massage is not going to make a huge difference to getting the placenta out. Okay. So massage is good for an atonic uterus to make it contract, but not for a retained placenta due to a sustained contraction. Okay. Right. How to diagnose uterine rupture? Not a topic today. I have a feeling I discussed it at some point, right? However, when we are looking at complicated or problems or emergencies in labor, we will go for uterine rupture as well. I remember talking about uterine rupture at some point somewhere, but we'll discuss that at length because it is an extremely important emergency which you need to know, right? Okay. So looks like we are done with our questions which we covered. Okay. Now I need to ask a question from you all, right? What are we going to do next? Are we going to now? Normally we do obstetrics, then gynecology, right? Do you all want me to continue into fetal monitoring next time, or because I have already done 2 sessions on obstetrics now, or do you want me to do a gynecology topic next time? What do you all want? Can you all quickly type in what you all require? Right, continue obstetrics, gynecology, finish labor, finish monitoring, obs, continue abnormal labor, gynecology topic, obs. Yeah, seems that everyone sort of wants to finish. Yeah. So what we'll do, children, yeah, is that we will do fetal monitoring in labor. Okay, because most of you all want that. So we'll do next time, we will do fetal monitoring that will have CTG. So I will complete CTG, that will take 1.5 to 2 hours actually. I will finish the CTG and give you an overall view about how to do fetal monitoring in labor. Okay. And then we will do a gyne topic and then go on to obstetric emergencies and management of different problems in obstetrics at a later date. Okay. Right. So I think we will wrap up because it's quite late, right? And then I will see you all next Wednesday, hopefully, if I'm not in, right? Okay then. Good night.
Thank you, sir.
Good night.
Thank you.